Hi, I'm Stephen Bruce. I run the Academy of Physical Medicine, and here's 45 minutes of free CPD for you. This is just an example of what we do. We run a free session every month, along with 70 plus hours of live learning with others CPD every year. If you'd like to see more, click the link in the info section below the video, and that'll take you through to our website. Enjoy. Can you, you might need to explain to people what exactly is going on in excavatum and carinatum.
Well, both conditions are problems with the growth plates within the chest. So typically there is a growth disturbance that normally happens in pre-adolescence or adolescence. And so that when there's that rapid onset of growth, the chest grows either asymmetrically or can grow symmetrically and out. So you get a convex chest, or it can go in concave chest. So the pectus carinatum is out, pectus excavatum is in. So here this is the excavatum. So here we've got two different types of excavatum. So excavatum, what we call localized, and excavatum wide. Both have rib flaring as well. You can see that the sort of like concavity to the ribs, and then the apex of the ribs is prominent. And quite often these conditions can be mixed as well. So you can get a little bit of carinatum and also an asymmetry to the excavatum as well. So there are some subtle differences within each presentation. That's the carinatum. So here we have the inferior, which is by far the most common thing we see in clinic, which is generally a symmetrical deformity around the line of the nipple. And it's by far the most common and by far probably the easiest to treat, but the condition which causes the most distress often. We have a pectus carinatum lateral, which obviously is the asymmetrical version, where the sternum is tilted to one side, and then the superior, which is quite rare and much higher up in the chest, and as a result much harder to treat, and you have to treat it a lot earlier and catch it earlier.
The central one there, the lateral one, difficult to work out exactly what's going on that one. Could you explain that?
So one side of the sternum is twisted, so that you have a prominence of the ribs and the sternum on one side. So we get a rotation like this.
Yeah. Okay. I see.
Yeah.
Yep. At what point do you decide to treat these things? I mean, presumably that they could develop in later life and become more serious than they are in youngsters.
Yeah, so I mean, really, you're treating for because someone becomes concerned about it, and the difficulty is it's always easier to treat younger because the chest is obviously more flexible. So in the superior carinatums, really, you need to be thinking about it at age 8, but often it goes unnoticed until it's a little bit too late with that category. With the pectus carinatum inferiors, you know, treating around between 12 to 15 is perfect, and the laterals may be a fraction early if you can catch it earlier. I mean, the main point is that a 12-year-old doesn't want to enter into treatment, and a 15-year-old does, and that's the difficulty. And a 17-year-old is desperate for treatment. So you're really trying to convince the 12-year-olds that it's a good idea to be wearing these braces, and they're not easy to wear. It's a very difficult treatment to deliver without complete compliance from the patient, and that's the way in which I was taught was it's all about compliance. So we can provide the tools, we can provide the expertise, but really the main skill that we deliver is convincing that patient that to keep going, and what can be quite a long-term treatment is seen to its fruition.
That's an interesting point you've brought up about compliance, because I would have thought that as you get into your mid-teens and later teens, both boys and girls are going to be very, very conscious of their appearance. And I would have thought perhaps even less likely to want to wear a brace of any sort.
You've got to have the driver, haven't you? So if you've got the driver of quite a large deformity of your chest, which, you know, socially causes problems, parents first see their children not wanting to go into the swim team anymore, or not wanting to play football, or not wanting to take their shirt off in public. It becomes quite a socially disabling condition. And, you know, traditionally, the way this was dealt with within the healthcare profession was a slap on the back and say, it doesn't make you any less a man, get on with it. And now, you know, even more so, when we first started doing this in 2010, that was very much the case, and people sort of, I think, in some respects, sneered at it, because we were the first people to bring this into the UK at the time. And now, with, you know, the mental health of us all, but often, you know, adolescents as well, is so important. Giving them just a chance to not have to live with a condition which is treatable is so important.
What is it we would notice? Would it be a fairly mild deformity that we might notice, and we would just need to alert the parent to the possibility that they should see, you know, someone expert in the condition?
Yeah, I mean, you know, a sternum and a rib cage should be, you know, should be flat and should be convex. So if you are noticing a protrusion or an asymmetry on the chest, first of all, that's, you know, a little bit of a red flag that maybe needs looking at. Secondly, you know, if you ever see a protrusion higher up in the chest here, that's certainly something in the younger child that should be directed to an expert to have a look at and see if that is a pectus carinatum superior. You're looking for rib flaring. So if there's a little bit of concavity, and then at the distal end of the ribs, you've got that prominence of the rib cage, that can be a sign that something is developing in the rib cage. Also, in the slightly older children, you get a lot more protraction of the shoulders, and then posturally they deteriorate quite a lot as they try and shrink their chest into their body. So that a lot of them can hide it actually very well with a t-shirt and pulling their t-shirt a little bit baggier and wearing jumpers and things, and they're slouching. And they, you know, their lumbar lordosis is very flat. They have an increased thoracic kyphosis to mask it and pull their chest away. And, you know, we want to, you know, stand them up and get them straight. When you do that, the chest really is very prominent. So it's amazing how people can hide it. The excavatums obviously are hidden much more easily, but and they are more obvious. I would say, you know, a word of sort of warning as well. You know, tread very carefully when you find these things, very gently. I mean, even, you know, offer some advice to the parents when the child's left the room, because so many of my older patients, you know, the 30-year-olds, you know, talk of an incident when a medical professional, either in A&E or at the time they saw a GP, went, "Oh, that's pectus carinatum, and yeah, he's going to have to live with that." And in a very blasé way, that child lives with that for the rest of their life and can be very upsetting. So dealing with it very subtly and gently. I mean, when we treat younger children, it's like brushing your teeth. It's something we're going to do every day. We don't wear the braces all day, every day. And we're trying to, it's like, you know, we play games, you blow up balloons, you really try and introduce it very gently and carefully into to a child, because it is quite, psychologically, it can be quite damaging.
Christina said that she has a patient who has the problem, and his young daughter also shows signs. So she's asking whether it is hereditary. Yeah,
so we see lots of sort of familial traits with it, and often the parents who have it will be just so, you know, on the lookout for this with their children. And if I ever see a young child, it's because the parents got it or a sibling's got it. One of the first boys I've treated back in 2010, I've seen 3 of his siblings. So and they got younger as the mum got more aware of the condition. So yeah, it's very we do see traits, brothers, twins, and parents. Yeah.
I guess my question is that you mentioned that, you know, as recently as 2010, people would say, "Oh, you've just got to live with that." Does that mean that if someone were to take their child to a GP, or if they themselves would go to a GP and say, "Look, I'm concerned about this," the GP might just dismiss it and say, "Well, you know."
Yeah, that certainly still happens today. So, and even if they find their way through to, you know, a thoracic consultant, in some areas, that can still happen. It is much better than it was, and certainly we receive referrals from thoracic consultants now. It's, you know, it's not treated under the NHS. I think to this date, I mean, surgery was recently pulled by the NHS as it's considered a cosmetic condition, which is so short-sighted for these patients, given the issue of mental health. And also, you know, one of the reasons people say it's just cosmetic is because it has no physiological problem. But around the age of 25, 26, I get a lot of patients who come in complaining with the excavatum, complaining of a tightness in their chest, and a shortening of their breath, and they can't quite do the same exercise as they once did. And I think, you know, I remember when I used to play football long ago, and I was 18, I used to bounce off the floor. And when I was 25, I didn't bounce, it hurt. The floor suddenly got a lot harder. And I think when that skeleton gets tougher and harder and stiffer, and you have an excavatum that's quite deep, you don't have the same lung capacity. So I do think there are some physical reasons for treating this and allowing patients to grow up with a normal chest shape, other than just the psychological benefits.
Yeah. You talked about 2 procedures, the NUS procedure and one other.
There was a ravage procedure as well, yeah.
What are they?
So NUS is when you put a bar into the chest, underneath the chest wall, and then it's bent before surgery, and then you flip it to then recreate the chest wall into the correct position, and then it's bolted to your rib cage, and then it's in for a couple of years, 3 years maybe, and then it's removed. If there's any surgeons watching this, I'm sure I've got the errors in that, and I'm not a surgeon, so it's a very layman's description. But and the ravage is when surgically they go in and almost do osteotomies on the rib cage and the sternum to put it back together again. It's far more invasive, the ravage procedure, and less common now, I think. But and for some chest wall problems, I think it's probably still the only option. But I think the NUS is by far the more common, and I think widely done and successful. But there are issues. You can't play contact sport whilst you're undergoing that period of treatment. And results don't sometimes take into consideration all of the rib flaring, which can be quite a problem, because you fix the ribs, you get a lovely flat chest here, but then you end up with 2 flared ribs. So, and we have sometimes seen those patients come through after their surgery.
Yeah. Scott has asked why NICE don't recommend the NUS procedure.
I think it's because I think they did. I think NICE were, but I think they have pulled it because it's cosmetic surgery. And again, I'm not up to date with the reasons behind it, but I know there are a lot of patients, and there's a lot of pressure on them to reinstate it. And I think they should. We're here to offer patients who don't want surgery, but I think there should certainly be a surgical option for patients as well.
Yeah. Earlier on, you made it sound as though the superior carinatum was a serious condition that had to be treated as soon as it was spotted. And then you went on to say, well, none of these things have a physiological effect.
Yeah, but it's quite psychologically, I think, for the superior carinatum patients, it's a problem. If posturally, it's a little bit easier to hide a carinatum. If you decide not to treat it, you can just protract your shoulders. You can end up with a back problem, but you can hide it a little bit more, and clothes tend to hang a little bit better lower down and things like that. The superior carinatums, especially in girls, is very difficult. They can't ever wear a top that comes down. It can be quite a very, very obvious condition with a big bone protruding out of the top of your chest. And the patients I've met with it are really quite upset by it. Unfortunately, it's the rarest, but yeah, so it's more, again, the psychological impact. It should not be underestimated, that impact. It can be life-changing. I've had patients say to me they've never been on a holiday with their friends. They never go swimming. They stop playing sport. And they don't go to the beach with their children, and they've got a wife and children, and they still are very, very emotionally upset by this. So it's
stating the obvious, it's going beyond the mental health, isn't it? Because if they've stopped exercise because of it as well, then it's going to have an impact on their overall health, not just their mental health. Absolutely.
And one of the, posturally, I think it's very important as well. One of the first things our patients see is an improvement in their posture. Sometimes they're exercising for the first time. Sometimes our patients are incredibly fit because they have exercised to try and get rid of the condition first. But sometimes if they haven't exercised, they start exercising, they start concentrating on their posture. We give them advice on that, of course. And the first thing that their friends, family, parents notice is, oh, the shoulders come back. They're standing up taller, their chin's tucked in. So it can have a significant effect on posture straight away.
Have both asked about the age range at which this can be treated. Jane's more specific. She says, how can she help a 25-year-old who has rib flare? And the other question is, can these conditions be treated at all ages? So
age is important, but flexibility is the key thing. So if you have a flexible chest, in theory, at any age, it can be treated. Now, so obviously we have a more flexible chest when we're younger, and that flexibility decreases as we get older. And as I said, we have treated younger children with both excavatum, especially excavatum, in fact, because if you can treat that younger with something called the vacuum bell, which is a suction cup that pulls the chest out along with a brace, you can sometimes never have to really go into the high intensity treatment of the 23 hours a day. And of course, this is a long-term treatment. So, starting in 2010, we've only got a handful of patients that we've really taken full, through, who were younger at the time and are now, 16, for example. But I tell the story often to my patients. I once had a very large muscular patient come in who was quite a robust chap, a bodybuilder, and he had a pectus carinatum. Now, to most people, you'd probably describe it as like a barrel chest historically, big barrel chest. But for him, it was quite upsetting. And when he came in, I thought, this is going to be tricky because I have to tell him he's not going to be treatable, because if you've done a lot of working out and you're in your 40s, which he was, it's a highly likely your chest is going to be rigid because of the stress you put through your chest and your age. And then when I felt his chest, it was hugely flexible. I was just, this is incredible. This is it's like a 16-year-old's chest. He says, yeah, I lie on a brick every night. I put a brick on the floor and I lie face down on it underneath my chest, and I keep it flexible, which was incredible, but he got a great result. So
we'll have to tuck that one away as special exercises for our patients. Prescribe them with a brick from the treatment.
I wouldn't advise it, but also he was the type of bloke you weren't going to argue with. So so he got a great result, and it just goes to show that its flexibility is key, not age.
Because we talked a little bit earlier on about how pectus deformities can change with age, and this one shows, I think, excavatum. I think it shows both of them actually changing.
There we go. Yeah.
Yeah, there we go. So that one. So I mean, some of those, I mean, the top two look quite severe actually. I mean, they look as though I can't imagine there is no physiological difficulty in either of those patients.
Well, you will be told, if you go to your consultant, you'll be told that it's just cosmetic. But I quite agree with you. Why would you not treat that? The important thing about those pictures is that's the same. Those are the same patient, and then that's them 4 years later, 6 years later. So at the top, and because when we started, we said that this is a problem of the growth plates. There are lesions within the growth plates of the chest. So as you grow, it gets worse. And often the first thing is that 10-year-old would have been told, don't worry, you'll grow out of this. They never grow out of it. You don't grow out of this condition. You get fat. That's what helps. So, if you've got carinatum and you get really chubby, you can hide it. But I also think, the healthcare professional that is telling you grow out of it has never reviewed the older patient. They perhaps send the patient away and just assume all their patients grow out of it. So
I have to say that lower picture, the 11-year-old to 15-year-old picture, just on the basis of those images, you wouldn't necessarily say there's anything going wrong there, would you? I suspect if you saw them in real life, you would notice something interesting.
So that sternum should really be vertical. So almost you could, if you drew a line down from where that right shoulder is, you could probably bring that chest almost straight down. So that's quite a large protrusion. This is why it's masked within the body type quite well. But if you rotated that round in 3D, you would see it, and actually it just doesn't look correct. And those patients, will be very upset by that condition. Also, with that type of chest, what's often masked is the rib flaring. As you push that rib flaring in and correct it, you see the ribs protrude more. And so those patients would need 2 braces to correct both areas.
Camelia has asked us a lot. I imagine a lot of people are quite keen to see what the braces look like. So if Justin can bring up the next slide, which is the braces, then that might be helpful.
Yeah. So at the top we've got a brace for pectus carinatum. That's a typical inferior carinatum brace, so a central pad. Quite often we will obviously adjust the size of the pads, obviously to the specific area that we're trying to put pressure, and also for the size of the patient. And on the bottom one's a brace to correct the rib flaring. They have a ratchet strap, and so they're dynamic, and so the patient can push in and loosen the brace depending on how they are tolerating it. And I often describe to the patient, you don't just push it in and hold it there. It's like this over time. You're pushing in, and slowly but surely you're increasing the pressure so that you get to a point where you are wearing those braces 23 hours a day and you're not feeling them, which sounds crazy, but actually in my carinatum 13, 14-year-olds, that can happen in a couple of weeks.
Really? And they're wearing them at night as well?
At night, yeah, at school. 23 hours a day. They take them off for contact sport. It shouldn't interfere with their sport. It's a big thing that I feel, you know, our children have to play sport. It's a lifelong skill that they learn and they love. And so taking kids away from their sport, I think is, you know, you have to do that very carefully. So the braces are taken off for sport. We minimize the time they're out of it. So they might take them to the changing rooms, take them off in the toilets beforehand, or if their mates are fine, take them off in the changing rooms, and then play the sport and come back and put them back on again.
Yeah. There's actually, I think, quite a useful sequence of slides coming up immediately after that last one, where you take us through a sequence of somebody being treated for pectus carinatum. Justin could bring those up. That would be quite useful. So this particular patient, I mean, that superior view looks quite dramatic.
So that it is, yeah. So that's it. So I always say this to patients when I take a 3D scan of their chest. I always show them that view on the 3D scan, and because you show them their sort of front on them view, and they go, yeah, and then you say, and this is what you're looking at, and that is it, isn't it? They're looking down all the time, going, oh my God, this is awful. So so treating it for them is far more important than the rest of the world. And so that's why we've got that slide in there, say that the patient's view.
And then the next one shows where you actually applied the pads. And in the 2 slides ago, I got the impression that the rib flare pads were only for excavatum. This one's for carinatum.
Yeah, so as you press, like I said earlier, as you press that carinatum in, you will then see the rib flare. I mean, almost 90% of my carinatum patients have rib flare. Sometimes the swimmers, the really good swimmers, will have such strong abs and obliques that they've held their ribs down and it's not a problem. But you know, most have some sort of rib flaring that occurs.
Dare I say this without, and I don't wish to sound in any way critical, I mean, that looks very basic and mechanical.
Yeah, it is.
Pads and steel straps.
Yeah, so it is essentially, it's like a piece of torture initially, and it's still, we need to have a gap all the way around. Also, the brace needs to last them sometimes, you know, 4 years. If we started treating at age 12 and we wanted to last to 16, so it needs to be robust, and also we need to grow it. So I've got a brace here. So you know, this brace, I will then, each time I see them, I will then bend the steel. Now you can do that in different ways. You could adjust it with straps and bars, but to keep it as sleek and as slim as possible, steel is pretty good. You know, it's a very good material for, you know, medical grade steel, obviously, but it's very good material for holding its shape and then being able to put it into a new shape and rebending it and then it holding its shape again. So they have some weight to it. That, you know, they're not light, but when they're strapped to your body, you don't feel that weight. And also, it means that if they're not strapped on tight, they will fall down, which again is a good thing, really, because you have to hold them on tight.
Could we quickly look at Pectus Excavatum and what you do for them? So, Justin, the first slide I think is somewhere around 25 on the deck, because it's slightly different, isn't it? You've got a sink plunger on the front of this one.
That's it. Yeah. So that's the vacuum bell. So the vacuum bell is a silicone suction cup, which comes in different sizes, and that is put onto the chest, and then we apply a vacuum pressure to pull the chest wall out. And at the same time, which I think is quite unusual, I don't know if anyone else is doing this anywhere that I've seen, we then apply a rib flaring brace to the bottom of the ribs, and you can often get a child with, you know, an excavatum, that boy will be standing with his chest wall in a normal position there. And so you can sometimes do that day one. You can put their chest into a normal position. And this whole treatment, we haven't spoken about this, but this whole treatment relies upon something called Wolff's Law, which is bony remodeling. And so the first stage of these treatments is to increase flexibility. So, you know, that chest is being pulled out every day until such time as you start to notice that it's taking longer and longer in between vacuum bell sessions for it to go back in, until it stays out until you put the vacuum bell on again. And at that point, that chest is remodeling. It's that the bones are now changing their structure so they sit permanently in that position. And as long as you maintain that until the driver, that growth driver, has stopped, so 16 and a half for boys, you get a permanent correction.
So that bell then is not being worn all the time?
No, so that bell is worn for minimum 2 to 3 hours a day. So homework, computer games, reading, whatever. But I've got more and more patients who are wearing them to sleep, and they're upping the hours, sometimes 6-7 hours a day. You know, the more you do it, the better result you get. I've got more patients, especially during the lockdown. Was like, you know, to go through this treatment during the lockdown was just a happy group of patients for a worldwide pandemic.
Yeah.
So
well, you reassured me, because of course, looking at the picture of the bell in place, I would have thought that's a lot more obvious under clothing than the
no. So the bell, sorry, yeah. So the bell is only worn for periods of the day, often, you know, in the house. I've got the odd patient who wears them in work. Some people just don't care as much as others. And so, but as long as you're getting that sort of, you know, a minimum sort of 2-3 hours a day, but I like to see more if I can, and those patients will get a quicker, faster result.
Overall, how long does a course of treatment take for a suitable correction to occur?
So, you know, a really compliant, you know, 13-year-old can have a flat chest inside 3 months, and they're starting to wean them out in 3 months. A very compliant 26-year-old with me with a lateral carinatum, so stiff, quite a stiff, difficult chest, he was weaning out in 9 months. They are my exceptions. I talk about a year to all my patients. And if I'm seeing an adult patient, certainly I'll talk about 18 months of you know, knowing them and being in treatment, with hopefully the intensive period being a year.